Assalamu alaikum and welcome back to another video. This video is going to be a continuation of the previous video, that's the management of diabetic ketoacidosis. If you haven't watched that video yet, you can click over here and it will take you to that video. We had few comments asking on how do we stop or taper the infusion, and also how do we convert to subcutaneous injection. So I'll be explaining on these topics and I'll be leaving the timestamps in the description below. Let's get started. Now that we have initiated insulin infusion, like we have explained in the previous video, there are a few aspects we need to look into before we plan on stopping the infusion and change to subcutaneous injection. They are an and gap, serum bicarbonate levels, patient's diet, and hemodynamic stability. Let's try to explain them. Coming to the first one, how do we calculate an and gap? It's a simple formula. Sodium minus chloride plus bicarbonate. A normal an and gap is generally 8 to 12. So if the value is anything above 12, we can say it's high an and gap. And we know it's one of the criteria met for the diagnosis of DKA. Coming to the second one, serum bicarbonate levels. In mild DKA, the bicarbonate levels can be in between 15 to 18 milliequivalents per liter, and in moderate or severe DKA, the value is going to be less than 15 milliequivalents per liter. So an improvement of bicarbonate levels above 15 milliequivalents is what we are aiming for. Coming to the third one, patient's diet. We want the patient to be orally accepting, and we should be charting a diabetic diet for him. And coming to the last one, patient should be hemodynamically stable. If all these are checked, we can plan on switching to subcutaneous injection. So we'll be using basal bolus insulin regimen, and we'll try to understand how to calculate the required dose. So coming to the first step of dose calculation. Total daily dose required will be 80% of the total daily insulin requirement on IV infusion for the last 24 hours. For example, if the patient is on infusion rate of 2 units per hour and his blood glucose levels are adequately controlled for the last 24 hours, with his vitals being stable with good oral acceptance, in this case, his total daily dose will be 80% of 2 into 24, which is going to be 38.4. Now I divide this value into 4 equal parts, of which 3 parts are going to be his bolus doses, and the 4th part will be his basal dose. So if you divide 38.4 by 4, the value is going to be 9.6. Let's round it to 10. So his bolus insulin dose, which needs to be received 30 minutes before each major meal, will be injection human actrapid 10 units subcutaneous before breakfast, injection human actrapid 10 units subcutaneous before lunch, and injection actrapid 10 units subcutaneous before dinner. And a basal insulin which needs to be received at bedtime, that's 2 hours after dinner, will be injection glargine, which is a long-acting insulin, 10 units subcutaneous at 10 p.m. And one important thing we need to remember is not to stop the insulin infusion abruptly. Rather, it should be overlapped with the basal bolus regimen 1 to 2 hours before stopping. Also, you need to monitor the GRB's value and titrate the dose further. So that's all for now. I hope this was helpful in understanding the management of diabetic ketoacidosis and the dose calculations. If you have any questions, do let me know, and also please let me know your feedback in the comments below. I'll see you in the next video. Thank you.